The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line.
Relies in your bag. That's right. Yeah, I forgot. I'm sorry. Okay. Relies sent me another thing also. They have rereads also from other doctors again that they don't trust. It's getting out of control.
Now, do they pay you for that?
Yeah, they pay me for reading the study.
Oh, okay. Don't forget the ski.
The webinar will begin shortly. Please remain on the line.
That's for Sandoz.
No, no. They want you to read. They want you.
Can you give me the bottle of water?
Oh, yeah, that's fine.
I need to clean my glasses too. Do you want to just clean them in the bathroom for a second?
Oh, okay.
Thank you.
The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line.
See, I never use the probes with that, you know, with the tramadol now. If I take one pill too much, you know, I get the nausea. Remember before I used to take 5, 6 and it didn't bother me?
Because I think you're weaned pretty well, though, Kay, don't you think? I mean,
I think so.
that's good, isn't it?
Yeah. Now
The webinar will begin shortly. Please remain on the
I'm sick
line.
as a dog from it.
Well, I mean, so you have it. You're okay now.
Yeah. I just didn't know. I just
Is this an hour or how long is this?
Yeah, probably about an hour.
Okay, because I'm gonna leave probably about a little after 11. It's
Yeah,
just to go to
yeah,
August.
that's
That's fine.
That's fine. And then I have to read those 4 studies first, or 5 studies first.
Okay.
And then I have to do that because Megan from Rely begged, Dr. Gant, can you please
The broadcast
you
is
know,
now
reread
starting.
that
All
study.
attendees are in listen-only mode.
Okay.
So, good afternoon to everybody out there. Welcome to the webinar entitled The Future of Hemodynamic Monitoring. This webinar is presented to you by the Cardiovascular Dynamics section of the European Society of Intensive Care Medicine. My name is Thomas Scheeren, and I'm working at the University Medical Center in Groningen in the Netherlands. I'm also the chair of the Cardiovascular Dynamics section of the European Society of Intensive Care Medicine. And my main topics of interest, as you presume, is cardiovascular physiology, in particular focusing on hemodynamic monitoring. Our main speaker today is Dr. Frederick Michard from Switzerland. Dr. Michard is a musician and researcher who was, among other things, involved in the development of pulse pressure variation as a tool to assess fluid responsiveness, a discovery that celebrated its 20th birthday recently. Besides working as an intensivist, he was also busy as consultant and employee of medical companies, and today leads his own company. In his multiple functions, he had insight into the present technological advances and future developments of hemodynamic monitoring devices, and I'm therefore looking very much forward to his talk on the future of hemodynamic monitoring. Before I hand over the microphone to Dr. Michard, I would like to remind you that you can ask questions during the presentation, which will then be collected by me and asked after the presentation to Dr. Michard. So please do not wait to ask your questions, to type your questions into the box at your right, and we will collect it. With that having said, please, Frederick, go ahead with your presentation.
Thank you very much, Thomas. Good afternoon, everyone, or good morning, depending where you are. First of all, thank you very much to the European Society for inviting me to give this lecture, and thank you to you, Thomas, for chairing the session. So the topic, as you mentioned, is the future of hemodynamic monitoring. And I have just a few slides to introduce myself before I start discussing hemodynamic monitoring. So I'm a French intensivist. I had the pleasure and privilege to work during many years with Jean-Louis Teboul and Denis Chemla in Paris, where together, as you mentioned, Thomas, we developed the concept of pulse pressure variation and fluid responsiveness. I did a fellowship in Boston at the Mass General Hospital in the surgical ICU. As you mentioned, I spent some time as well working with or for industry, developing some graphical display, working more recently on health economic questions. But today I'm living and working in Switzerland, where 3 years ago I founded a consulting company, MICO, based in what we call the Swiss Silicon Valley, and where we focus on digital innovations with medical applications. So you may have seen some of these recent publications. And this one about wireless and wearable sensors. This one about smartphones. But clearly this is not the topic for today. The topic for today is the future of hemodynamic monitoring. So as you can imagine, I don't have a crystal ball, so I don't know exactly what's going to happen in 5 to 10 years from now. But at least I can share with you my vision. The vision from someone with clinical research and, as I just mentioned, also industry experience. And as a matter of fact, regarding hemodynamic monitoring, I have some news I would like to share with you. News. NEWS. So the N would stand for non-invasive. I believe, I suspect we'll use more and more non-invasive technologies in the future for obvious reasons, to prevent thrombotic, hemorrhagic, and infectious complications associated with invasive technologies. Actually, we don't have to wait. There are already non-invasive solutions on the market. You see here the example of bioimpedance tracheal tube and bioreactance electrodes you could use to monitor blood flow, cardiac output if you prefer, continuously. At the bottom, you have volume clamp techniques, and on the right-hand side, tonometric technique that would give you blood pressure waveform continuously. And because these systems are also equipped with a pulse control algorithm, they compute stroke volume and cardiac output from the blood pressure waveform. And so you can also measure and monitor blood flow from these technologies. In the future, I suspect we'll be able to measure SCVO2 as well non-invasively. This is just an example. This is a near sensor. So I'm sure many of you are familiar with this technology. Maybe some of you actually already use it to monitor brain oxygenation. So the principle is exactly the same, but the sensor would be positioned next to the jugular vein to measure continuously SCVO2. This is another example of a product which is not yet approved for medical use, but which is currently under development. It's a wearable Doppler patch that was designed for monitoring continuously carotid blood flow, or actually more specifically carotid blood velocity. And we could imagine in the future to use these kind of sensors during, for example, the passive leg raising maneuver to detect acute dynamic changes in carotid blood velocity and predict fluid responsiveness. Blood pressure is a very important hemodynamic variable, and we measure blood pressure in most patients undergoing surgery, and in many patients who are in the ICU, with a brachial cuff, with the oscillometric brachial cuff method, knowing that this method is far to be perfect. As you know, many studies have reported significant discrepancies between invasive and non-invasive measurements, and this one from WAX is actually a very large study published in Anesthesiology a few years ago. And you can see that particularly for extreme values, very low blood pressure or very high blood pressure values, there is a very significant discrepancy between the measurements coming from the brachial cuff and the measurements coming from the radial catheter. This is one of these studies coming from your group, Thomas, published a few years ago in the British Journal of Anesthesiology, and comparing again invasive to non-invasive measurements done with the brachial cuff. And in this paper, you showed that actually the accuracy is pretty good because the bias, which is the average difference between the two techniques, was 0. But the precision, the standard deviation, was not that good. It was 12 millimeters of mercury, which is less than the requirement by the Association for Medical Instrumentation. So the good news is that actually the brachial cuff was recently revisited with a rigid shell and more importantly with a hydraulic pressure sensor pad. So you probably know that air is actually a shock absorber or a damper. And so today, in black, you have or you see the oscillation we can record with a classical brachial curve, with a classical brachial curve. In blue, that's actually the new signal we are able to record with this new hydraulic coupling sensor. As a result, actually, the precision was improved. I share with you the results of clinical evaluation, which is not yet published, but coming from 3 German hospitals. And you can see a significant number of surgical patients, a large number of measurements. I show you here the results for the mean arterial pressure. And you see the bias was close to 0. So the technology is pretty accurate, but more importantly, the standard deviation is pretty low, meaning the technique is more precise than the brachial curve we are using today. What's interesting, and I believe even more interesting, that this discrepancy we had for very low or very high values actually disappeared. I show on the left side of the slide, you have again the results from the study by wax. And on the right side of the slide, you have actually the results of the measurements obtained with this new hydraulic brachial curve. On the top of that, as you understood, we have access to blood pressure waveform for about 60 seconds when we use this system, meaning in the future we should be able to get PPV and also cardiac output with the appropriate pulse contour technique. Echocardiography now. As you know, probably better than me, echo is a very important technology for the management of patients with shock. And when I was a resident, that's the kind of machines, right, we had to use. Actually, I had to bring it from the cardiology department. We actually did not have any echo machine in the ICU at that time. And as you know, these machines became smaller and smaller, and today they actually fit in your pocket. Thanks to technological improvement, we can actually today buy a probe or order a probe on the web. And once you receive it, you just have to connect it to your cell phone, and you can perform a qualitative evaluation of cardiac function. So clearly, you cannot measure cardiac output because these probes are not equipped with pulse Doppler, but you can use them for qualitative evaluation of cardiac function, which is, as you know, very useful in many clinical situations. TE is evolving as well. This is a disposable TE probe. You can leave in place up to 72 hours, and you can use for continuous visual monitoring of cardiac function. So you can, for instance, look at the left ventricular filling, you can look at right ventricular function, you can even look at the superior vena cava collapsibility in mechanically ventilated patients if you want to predict fluid responsiveness. So a large study was actually completed last year by the team of Juka Takala. I don't know the results, but I guess it will be published this year. And this is an outcome study, so we will know if using this kind of tool is helpful or not to improve quality of care. The E of news would stand for ergonomic and easy to use. I'm convinced we'll use more and more ergonomic tools. Monitoring systems able to integrate multiple sensors. So this is just an example. This is not an existing technology. But we can easily envision that in the future, anesthesiologists will use these kind of helmets, to monitor depth of anesthesia, to monitor SpO2, SBHB, to monitor blood pressure from the temporal artery, and then, of course, have access to PPV, have access to stroke volume and cardiac output, assuming there is a pulse control algorithm on board to measure temperature, of course, and brain oxygenation. So this kind of ergonomic system will not only make our life easier, it will help us to integrate the information, because data integration is also something very important. That's actually what you do, what we do today, to make therapeutic decisions. I use here a very simple example, a very common example, which is intraoperative hypotension. When the blood pressure drops during surgery, you may want to give inotropes or fluid or red blood cells or vasopressors, or maybe simply to decrease depth of anesthesia. But to make a good decision, you need to know what's going on. You need to know what are the underlying mechanisms of hypertension. And so you need to integrate the information you have access to. I say that ease of use is also key because I think it's absolutely key for clinical adoption. And that's probably the reason why uncalibrated pulse contour techniques, which, as we all know, are not the most accurate and precise techniques to measure cardiac output, are so widely used today, at least during surgery for hemodynamic monitoring. As you can see in these two large trials published in really top journals, almost 75% of anesthesiologists, when they were using a hemodynamic monitoring tool, it was a pulse contour technique. So for that reason, because of this clinical adoption, I suspect that bedside monitoring companies will at some point develop their own pulse contour algorithm or simply acquire pulse contour algorithm available on the market. And so in the future, assuming you monitor continuously blood pressure in your patient, will give you cardiac output and stroke volume values next to more classical physiological numbers. Having said that, we should not forget that the main goal, the ultimate goal of hemodynamic management is to preserve or to improve tissue perfusion. In other words, to keep our cells happy. And today we can already envision to monitor mitochondrial PO2. I show you here the example of a technique that was developed. So the technology is not yet available on the market, but there are already several publications showing that with this optical method, it may become possible to monitor mitochondrial oxygen consumption continuously. What's already possible today is to look at the microvessels. You know, there are different techniques available on the market you can use to assess sublingual microcirculation. And I really invite you to read this report published in Intensive Care Medicine last year, where all these experts explain very well, discuss and describe very well what are the potential values and applications of monitoring microcirculation. They also clearly acknowledge the limitations of current tools and the fact that they are actually mainly available or usable for research today. What we would need is something easy to use, something providing a non-operator dependent and continuous evaluation of microcirculation. And so that's why I think this new smart Foley catheter may be interesting. It's actually a Foley catheter, as you can see, with a PPG sensor, enabling the continuous monitoring of perfusion index. And so in this experimental study, what we did is that we induced a decrease in blood pressure simply by increasing depth of anesthesia. So in the figure, you see the mean arterial pressure on the x-axis, and you see the perfusion index on the y-axis. And you can see that when we decrease mean arterial pressure, we observe a parallel decrease in perfusion index. Then we gave norepinephrine to normalize the mean arterial pressure. And you see the rise in MAP followed by the rise in perfusion index. And we continued to give norepinephrine. The goal was to reach a MAP around 100 millimeters of mercury. And then what we observed was very interesting. There is again a very significant relationship between MAP and PI, but you see it became an inverse relationship. So when we increased MAP, we actually decreased perfusion index. And this is known as the dissociation or the possible dissociation between macro and micro circulation. And so these kind of tools may help us in the future to individualize vasopressor therapy by identifying what is the optimal mean arterial pressure for any given patient. The W now, the W of news would stand for wearable and wireless. Everything we use today, all the technologies you are using, or at least most of them are wireless, right? Not much yet in the OR and the AC. So we need we definitely need wireless solutions as well in acute care settings. First of all, to make our life easier, to get rid of what has been called the spaghetti syndrome, you know, all these cables and wires engulfing our patients. It will make our life easier, but more importantly, it will give us the opportunity to monitor patients beyond the OR and the ICU. And this might be actually the next major opportunity to improve patient safety. So why? I don't know if you remember this study from Pierce and co-workers published in the Lancet a few years ago. A large study, large number of patients, almost 500 hospitals from 28 European countries. They focused on non-cardiac surgical patients, and some patients died after surgery. One of the most important findings was that most patients who died were not admitted to critical care at any stage. They actually died on the wards. This is another very interesting study. It's a study, it's a national cardiac arrest audit led by Jerry Nolan from the UK. And they looked at the location of arrest for over 23,000 patients. And you see once again that actually it happened most of the time on the wards, not in acute care settings. And the thing is that on the wards, not all, but most patients don't suddenly deteriorate. We actually suddenly notice because nurses are doing spot check of vital signs only every 4 to 6 to 8 hours. So clearly the introduction of continuous monitoring has potential to improve the quality of care on the wards. The good news is that we start to see some mobile monitoring techniques we can use to monitor vital signs on the wards. You see here a few examples. And we also start to see outcome studies showing benefits. That's a recent study from Chris Soubé, Bernd Duller, and Rinaldo Beomo. The study was done in the UK. They did implement this wireless monitoring system on the wards, and were able to report a significant decrease in cardiac arrest and mortality. The idea, of course, is to detect at a pretty early stage clinical deterioration. So you are able to act early to prevent clinical deterioration, ICU admission, and sometimes cardiac arrest and even death. There are actually more and more sensors you can use to monitor patients on the wards, and all the examples I'm sharing with you right now are actually FDA. But they do not measure blood pressure. That's one of the limitations we have to do. But is it really necessary to measure blood pressure on the wards? I don't know if you have seen this recent paper from the team of Dan Sessler, published in Anesthesiology. They report the association between post-operative complications, for instance, myocardial infarction and death, and hypotension. And you see and you know that when patients develop hypertension during surgery, I mean, there is indeed a significant increase in the number of patients who develop myocardial infarction and death. And you see it's a plus 8% increase for intraoperative hypertension. But look at what's happening when patients develop hypertension between day 1 and day 4, that is to say when most of the time they are on the wards. The association between hypertension and myocardial infarction and death is really impressive. So that's what I call the monitoring paradox. Today we monitor blood pressure very closely during surgery and right after surgery when patients go to the PACU, but not on the wards. This study is also very interesting, coming again from the team of Dan Sessler, and I thank him for giving me the opportunity, the authorization actually to share with you, because it's not yet published, but it's in press in anesthesiology. What they did is actually pretty simple. Nurses were doing spot check of blood pressure every 4 hours on the wards, but they were also recording continuously blood pressure with a non-invasive system. But clinicians were not aware about the values. And then at the end, they looked at the number of hypotensive events that were missed between the different spot check. And they realized, and you will see it's part of the publication, that 47, so almost half of hypotensive events were actually missed just because today we did not monitor blood pressure continuously on the wards. So clearly, there is room for improvement on the wards. And the good news is that we start seeing some technologies we could possibly use to monitor blood pressure on the ward. So here is an example of a pulse decomposition system. So as you can see, there is a small finger sensor that is connected to a piezoelectric sensor, part of the wrist unit, and information is transmitted wirelessly to a tablet. So in this example, that could be any monitoring system. And there are also some techniques based on the estimation of the pulse wave transit time. So as you probably know, the pulse wave transit time depends on blood pressure. So actually in practice, you cannot accurately measure blood pressure from the pulse wave transit time, but at least you can detect changes. And so these techniques are designed to detect a drop in blood pressure, and this drop in blood pressure can be used, for example, to trigger a real measurement of blood pressure with a brachial. In the future, I think we'll use different technologies, thanks to new materials, nanotech, flexible electronics, and 3D printers. I mean, that's an example of what scientists and engineers are currently developing. It's clearly far to market, maybe in 10 years from now, we'll be able to start using these techniques. But you see, they are very impressive. I mean, these are very small sensors. They are wireless. If you position them on the radial artery, you can, or on the carotid artery, you can record high fidelity blood pressure waveforms. You see the dichrotic notch. And so that could be very useful to monitor patients, ambulatory patients in the future. Then I'm going to focus on S. So S would stand for smart. First of all, I think we have to become a bit smarter. We have to acknowledge that one size cannot fit all patients. And first of all, regarding fluid administration, I will just use the example of surgical patients, because I think it's easy to understand that during surgery, I mean, we cannot consider all patients are alike because of comorbidities, because of the clinical context, because of what happened before surgery. Could be bowel preparation, preoperative hydration, could be pre-injection IV loading, and of course, because of what's going to happen during surgery and operative blood loss, there are not two patients alike with regard to their volume status. There is a large variability in volume status, explaining that some patients may benefit from receiving a lot of fluid, and other patients may actually benefit from fluid restriction. So this is clearly a plea for what has been called individualized fluid therapy. And today, as you know, there are many methods and techniques which have been proposed to individualize fluid therapy to ensure you don't give fluid to patients who will not benefit from fluid administration. And so these methods range from the mere observation of a variable like pulse pressure variation to the passive leg rising maneuver, which is, as you know, a very elegant way to predict the effect of fluid administration without giving a single drop of fluid. You mimic the effect of fluid administration. And other methods have been proposed and described, most of them by the team of Jean-Louis Teboul. But I will just focus on one you probably know a bit less, but in my opinion is promising, which is a recruitment maneuver. The recruitment maneuver, because it's done automatically by more and more anesthesia machine and mechanical ventilators, and because it's part of what has been described as protective mechanical ventilation. And so in this study, Mathieu Bier 2 years ago showed very nicely that what's happening during a recruitment maneuver from an hemodynamic standpoint is very useful to predict fluid responses. There are basically two patterns. You see on the left patients in whom during the recruitment maneuver there is a dramatic decrease in stroke volume. And here you have patients in whom you observe a decrease in stroke volume, but it's not that dramatic. So Mathieu showed that when you observe a dramatic decrease in stroke volume during the maneuver, you can bet your patient is going to be responder to fluid administration. And so this is known now as the 3 times 30 maneuver and could become automatic. And I show you here an example. You see a patient. So if we apply 30 centimeters of water, so in green you have the peak airway pressure, in blue you have the stroke volume, which is monitored continuously and simultaneously. So if we apply 30 centimeters of water for 30 seconds, if you observe a decrease in stroke volume which is less than 30%, you can bet your patient is not going to be fluid responsive. And you can see in this example, when the patient receives fluid, no change in stroke volume. In this example, in contrast, when they applied 30 centimeters of water for 30 seconds, they observed a dramatic decrease in stroke volume. And so they were able to predict fluid responsiveness. And indeed, when these patients receive fluid, you see a progressive rise in stroke volume. So clearly in the future, I mean, I think it will become automatic. Each time the anesthesia machine or the mechanical ventilator will perform a recruitment maneuver, assuming the monitoring system will be able to monitor stroke volume at the same time. These machines will be able to tell you if your patient is fluid responsive or not. And of course, to prevent, that will be very useful and mainly useful to prevent unjustified fluid administration in non-responder patients. Another very interesting concept I'd like to discuss with you, and you see there is a lot to discuss on this topic, is personalized hemodynamic management. The idea is to use personal hemodynamic variables as targets during surgery. So for example, blood pressure. I know your blood pressure before surgery, the one I'm going to measure during the preoperative visit, and I'm going to use it as a target during surgery. So as you probably know, this is what Emmanuel Futtier, Samir Jaber, and others have done in this very nice paper published in the JAMA. And they showed a dramatic improvement in postoperative outcome, a significant difference with regard to postoperative organ dysfunction, with a better outcome in patients who were first fluid optimized, and then in whom norepinephrine was used to ensure that the blood pressure values during surgery were remaining close to their personal blood pressure values. Of course, you cannot measure blood pressure just right before surgery because of the stress, because of premedication. So the blood pressure measurements were done the day before surgery on the wards, or even during the preoperative visit. We can imagine to do the same for cardiac output, assuming we are able to measure cardiac output before surgery. And this is actually what Bernd Sögel from Hamburg did last year. I mean, they completed a study as well. The results should be published this year. And so they used to measure cardiac output before surgery, actually the day before surgery on the wards, a volume clamp technique, a reusable volume clamp technique. But they could have used an echo machine, they could have used a suprasternal Doppler system, or they could even have used this bioimpedance necklace that was recently approved by the FDA to measure stroke volume and cardiac output. Smart monitoring also means decision support tools. I just mentioned echo. Be aware there are today software that are designed to help you do your echo measurements, even if you are not a top expert. And I'll show you, I share with you as an example. This software is designed to help you measure, I would not say easily, but more easily, VTI, so velocity time integral at the level of the left ventricular outflow tract, which is a surrogate for stroke volume, as you know. It helps you as well to monitor or to measure, to quantify the respiratory variation in inferior vena cava diameter to predict fluid responsiveness in mechanically ventilated patients. And it would help you as well to detect and quantify B lines, which, as you know, are a marker of pulmonary edema. Visual decision support tools are also available, and I think you will see more and more in the future. I share with you here some published examples of target screens, which have been developed mainly for anesthesiologists who are interested in following gold-active fluid therapy protocols and improving compliance to the protocol. And as a matter of fact, this is a recent study from Alexandre Justin and others showing that these decision support tools tools are actually useful to improve protocol adherence in surgical patients, assuming, of course, you are using a gold active fluid therapy protocol for high-risk surgical patients. SMART finally could also mean predictive analytics. So I'm sure you heard about predictive analytics, about machine learning systems. The idea is to predict adverse events. Actually, not to predict them before they happen, but before they become visible to clinicians. In the OR, I'm sure you have seen these recent papers published in anesthesiology, where they used waveform features from your pulse or from the pulse, recorded with an line, to predict hypertension during surgery. And they were able to predict 5 minutes, 10 minutes, or even 15 minutes before hypertension occurs, with pretty good sensitivity and specificity. This is a more recent study done with the same system, showing less impressive results, but still some predictive value. In the ICU, this is a study where they try to detect some signatures of adverse events in ICU patients. So what they try to predict were intubation, sepsis, and hemorrhage. And to do so, they used physiological variables to feed their predictive algorithm. And that's what they ended up. You see the C statistics, ranging between 0.68 and 0.77, meaning that the sensitivities and specificities was also among the same range, somewhere between 65% up to 80% best case scenario. So that's clearly much better than tossing a coin, and that's clearly useful if you want to compare patient population. But that's maybe a bit more challenging if you plan to use this predictive algorithm to make a decision in the individual patient. So that's why Tim Buckman, you probably or possibly know him, is the editor-in-chief as the editor-in-chief of Critical Care Medicine, tried to improve the sensitivity and specificity by adding more variables to the predictive algorithm. So they use 65 variables coming from the electronic medical records, including vital signs and heart rate and blood pressure as hemodynamic variables. And for a sensitivity of 85%, they were able to predict sepsis with a specificity of 67%. So once again, it's better than the random guess. But there are some false positives, raising question the clinical usefulness of this specific algorithm in individual patients. In step-down units, this is the well-done work by Marilyn Ravnak and Michael Pinsky about the biosignal index, which is a fusion of heart rate, respiratory rate, SpO2, and non-invasive blood pressure. And they showed that this biosignal index is useful to detect cardiorespiratory instability beforehand. But actually, they did not compare the predictive value of these new and sophisticated score developed from machine learning systems with classical early warning scores we are using today on the world to detect clinical deterioration at the early stage. In contrast, Dana Edelson from Chicago and Mansour Peck developed a new score they call the ECART, which is a fusion of age, vital signs, lab data, including, of course, heart rate and blood pressure. And they showed in this paper that the ECART seems to be the best score we know today to predict clinical deterioration on the ward. And you see it was performing better than the NEWS, the National Early Warning Score, or the MUSE, the Modified Early Warning Score, and of course, better than any single vital sign. So the idea, of course, in the future is to use this machine learning algorithm, first of all, for risk stratification. So when patients will be admitted, as soon as we have enough data to crunch, we will be able to predict adverse events. And if patients are at low risk to develop adverse events, and probably we will continue to do spot check only every 4 to 6 hours. But if the risk is higher, we can decide to do more frequent spot check, or even to monitor continuously patients on the roads. And then this predictive analytics software will help us as well when patients are monitored continuously to filter the artifact, to fuse information, and to predict adverse events, so that clinicians will be informed immediately as soon as patients start to deteriorate, and it will be the opportunity to prevent some of the ICU admissions and to improve outcomes. So just to summarize regarding predictive analytics, as you understood, a very active research field. I think today we still need more studies to clarify what could be the clinical applications. In conclusion, I think we'll use more and more non-invasive technologies for obvious reasons to prevent complications associated with invasiveness. Ergonomic monitoring systems, it will not only make our life easier, but as you understood, it will help us to integrate information, data integration being a key element of the decision-making system. We will use more and more wireless and wearable sensors. Again, it will also make our life easier, but more importantly, you understood it will help us to expand export monitoring beyond the OR and the ICU. And finally, I think we'll use also smart software and algorithms that will not only help us to understand what's going on, to make therapeutic decisions, but also maybe to predict adverse events. With that, I want to thank you for your attention. I know we are going to have a discussion now, but if for any reason you have no time to ask your questions, feel free to shoot me an email, and I will be very happy to continue the discussion with you on the web. Thank you very much.
Thank you very much, Frederick. This was an excellent overview over the current and future technologies, and I guess there's a lot of stuff to discuss. There are already questions coming in related to your talk. I guess we should start with that. So the first questions, I don't know if you can also see them, otherwise I will read it for everyone, is about the smart Foley catheter that you showed in your presentation. And the question is, for the smart Foley, how can you trust that the perfusion index truly correlates with the microcirculation changes, and what is the effect of temperature?
Okay, so yeah. We don't know yet what is the effect of temperature. I mean, as I showed you, this is a very first animal study, and so what we wanted to check is that actually this what we measure is clearly following first of all macro hemodynamic variables. So I showed you that when we decrease blood pressure or we increase blood pressure, we have parallel changes in perfusion index. So obviously we are measuring something which is related to what's happening in the vessels. It's a hemodynamic variable, and as I showed you, at some point above a given mean arterial pressure, which actually not the same from one peak to the other, and that's what I think is very interesting. When we further increase blood pressure, we actually observe the dissociation. So the dissociation, you know, I mentioned in my presentation, I think a very important article that we should all read, which is the consensus expert paper about the potential value of microcirculation monitoring. And so they clearly explain the issue of lack of currents sometimes, and actually most of the time today, because we don't monitor or we don't look at microcirculation. We simply, I would say, normalize or optimize blood pressure and cardiac output. And sometimes, as a matter of fact, we probably give too much, for instance, vasopressors. And even if we are happy with the blood pressure and with the cardiac output values, obviously we may actually decrease, have side effect on microcirculation. So I think this smart Foley catheter is potentially interesting to tracking these, detecting this lack of currents, this dissociation. But at this stage, you know, we don't know more about what is the exact meaning and what are all the determinants of what we measure. and also, of course, what could be the impact and outcome in the future. That's the very first step. But once again, I mean, the lecture was about the future, so I had to share with you some very, very new information. I think that many of you were expecting that, and so meaning I will not have an answer to all your questions.
And so meaning I will not have an answer.
You showed even unpublished results. Very nice. So excellent. Thank you for this answer. The next question relates to the wearable devices that you showed us. And the question is, where the wearable devices compared to the modified early warning score or other warning systems traditionally used? I think you partially answered that for this one publication that you showed, but are you aware of any publications comparing these devices to the existing scores?
So yeah, but I think it's not one or the other. I mean, you are going to use wearable devices, sensors to measure, to collect heart rate, blood pressure, respiratory rate, SpO2, and temperature. And this information will be used to calculate a warning score. So it could be the news, as in the question, could be the news, could be the views. As you know, there are many different scores which have been proposed. So it's not one or the other. It's actually using new technologies to replace the nurse, if you want, and to continuously monitor and compute the warning scores, so that as soon as the warning score is above a given threshold value, the system will automatically inform the nurse or inform you, depending on the warning score, on your pager or on your cell phone. And to further answer the question, yes, there are already a few studies showing that when monitoring systems are used to automatically calculate early warning scores and to inform immediately clinicians about clinical deterioration, it is indeed associated with a better outcome. There are studies showing a decrease in the number of ICU admissions, studies showing a decrease in hospital length of stay, and I shared with you a study showing actually a decrease in mortality.
So could you imagine that the future role of the anesthesiologist or the intensivist would be not sitting next to the patient bed instead of sitting in front of a monitor screen where all these signals from all the wards and the patients come in and just react when there is something going wrong? Is it the future?
No, of course not. Of course not. But I think it will give nurses more time to discuss with the patient, to deal with other issues. You know, it's not all about the vital signs. The vital signs are obviously very important to detect clinical deterioration. But I think many patients today complain when they spend time at the hospital that they don't see enough the doctors, they don't see enough the nurses, because they are busy monitoring and recording all these variables. That's what nurses are doing all day, going from one room to the other and taking vital signs. So actually these tools should potentially help us, help nurses to decrease workload and give them the opportunity to focus on patients who are really deteriorating as soon as they deteriorate. And on the top of that, also to improve the comfort and patient satisfaction of patients who are stable. Because if I just use the example of sleep disorder, it's a big issue in the hospital. Okay, I'm not a specialist, but I've seen a few papers. And I can easily understand it's a big problem. So why taking the blood pressure, why waking up a patient early in the morning or late in the evening to check the vitals, if actually there are non-invasive sensors we can now use that will do the job continuously and without disturbing the patient during his sleep. So there are many potential advantages associated with the use of these new technologies. But as I said, it's still a long way. We are just at the beginning. We start to have the opportunity to use these tools. There are some limitations, some challenges, but I think the potential is there to improve quality of care and also to improve patient satisfaction.
The next question is about the prediction of fluid responsiveness. You showed us several methods able to do that. And the question is directly to you. if you, the presenter, was to choose one of these methods for the prediction of fluid responsiveness, what will it be going to be? So which method would you choose personally?
Yes, I think the answer was actually in my. I think the answer was in my selection. If I can use PPV, I use PPV because I have the information, it's so easy to use. But as you know, there are limitations. So when there are limitations, if I am in the ICU, I think I will use a passive leg raising maneuver because that's something nurses can do that. And so they can tell us, they know, immediately or not immediately, but in a few minutes, you know if your patient is fully responder or not. In the OR, I would use a recruitment maneuver. And my hope is that it will become automatic in the future.
And then we have one comment from Dr. Munka. He's involved in the development of this mitochondrial monitor that you mentioned, and he was just mentioning that mitochondrial oxygen measurement is not on the development, it's already available in clinical use. That's the COMET monitor.
Okay, I didn't want to mention any brand name, but okay. I'm sorry for the wrong information.
I'm sorry for the wrong information. Next question is, have any of these novel monitoring techniques been incorporated at a hospital level? And if so, what is the impact on logistics?
Can you repeat, Thomas? Was about ward monitoring?
Can you repeat, have any of these novel monitoring techniques, I think it's broader than that, any of these novel monitoring techniques been incorporated at a hospital level? So if I understand the question correctly, is at the whole hospital level, so not only one department using it? And if so, what is the impact on logistics?
I assume, Thomas, the question is more about ward monitoring, because at the beginning I mentioned techniques we can use during surgery or in the ICU, and many of the techniques I described, as you understood, actually are already on the market, could be used for hemodynamic monitoring today. So I suspect the question is more about the wireless sensors. Yes, some hospitals started to implement. Basically, the hospitals who published positive results showing improvement in outcome. So there are some hospitals in the US, and actually many in the US, I think, who are using these technologies. But it's coming, as I said, most of these technologies are new, and so we have to wait a little bit to know exactly what is the impact on clinical outcome, and also what is the economic impact.
On clinical outcome, but also the economic impact. The next question comes from Turkey, I guess. It's about the bioprobes that you showed, and the question is, are they useful also for pediatric age, and are they compatible with any cell phone that is on the market, or are there restrictions?
Excuse me, which bioprobe? Because I probably showed you like 55 different techniques in the presentation. So which one do they have in mind, or do you have in mind? So which one?
I'm not sure what
okay, so maybe this gentleman or this lady could shoot me an email. No problem to answer by email.
But you mentioned, for example, the echo probe, which could be connected.
The TE probe, as far as I know, it's for adults only, but I wouldn't say, I wouldn't share wrong information. You already did mistake regarding mitochondrial IPO2. We apologize again about that, but I don't know for the TE probe. At least in publication I have seen, it's exclusively used in adult patients.
And does it go with any cell phone, or do you need a special brand?
For the disposable TE probe today, it doesn't work with a cell phone. The TE probe works with a specific standalone monitor. If the question was related to the probe you can buy on the web, I mean, yes, you can use it for actually not only for echocardiography, you can use it for any echo evaluation, and not only in adult patients. I mean, this is just an echo probe, so there's no reason not to use it in pediatrics.
All right. The next question is about the financial implications. You mentioned in the beginning of your talk about this mercy equation. So the question is, what kind of financial implication as compared to present technology should we expect, particularly for ICU patients?
So you mentioned the Mercy equation. The Mercy equation is a very simple equation that can help you to assess a return on investment. I think there is no magic answer, but the message I can share with you is that when looking at the cost of any new technology, and it's not even specific to monitoring technologies, but each time we bring a new technique to the hospital, each time we believe a new technology may help us to improve outcome, it's very important when looking at the economic implications or impact to consider not only the cost of the technology, but also the potential savings associated with improved outcome. For instance, if you decrease complication or if you decrease length of stay, it will be associated with potential savings for the hospital. So what's really important is to compare the investment you have to make, the money you have to spend, and the potential savings. That's the principle. Then, you have to assess the impact, the economic impact in your own institution, in your own country, with the technology you want to implement. I mean, it will really depend, the result will really depend on what you are doing for which patients and where you work.
Excellent. The next question is about the recruitment maneuver that you mentioned in your presentation. The question is, does the recruitment have the same limitation as the PPV? Maybe you could talk about this limitation.
Actually, so thanks to raising this point. When Thomas asked me which method should I use, so I would use PPV when I can, but when there are limitations, I would use a passive leg raising maneuver. So when I do a passive leg raising maneuver, I need to be able to measure stroke volume. Okay, so I will rely on stroke volume evaluation assessment during the maneuver. Same for the recruitment maneuver. The recruitment maneuver, I need to be able to monitor stroke volume continuously. So that's a method you can use, for example, during protective mechanical ventilation, even if your tidal volume is 6 ml per kilogram, even if the abdomen or the thorax is open, even if not if the thorax is open for the recruitment maneuver, but if the abdomen, if you are, for example, during a laparoscopic case where there is a significant increase in abdominal pressure, that could be a problem to interpret PPV. So if the patient has AFib, all these classical limitations to the use of PPV, if you are able to monitor stroke volume during a passive leg raising maneuver or during a recruitment maneuver, of course you can predict fluid responsiveness. That's actually the reason why these methods have been developed. They were built on the limitations of PPV, SPV, PVI.
Great. The next question is about the Swan-Ganz catheter. You didn't mention it in your presentation, so it obviously has no role in the future. And the question is then, are we closing the Swan-Ganz final, or do we need it anymore? What do you think?
I don't know. I was just unable to share new information with you about this one. But as you know better than me, Thomas, because you are in charge, I think, of your cardiovascular department, I mean, I think you continue to use this one, at least for cardiac surgical patients. So my feeling is that it's still used in a significant number of patients.
It's still used in a lot of people could join only halfway and ask if the presentation will be joined later. I think it will be on the website shortly.
That's my understanding as well. Yeah.
Yes, for all those who missed part of it or who want to repeat it, it will be on the website. I think within a week from now, it should be no problem. Let me ask you a question. You mentioned at the end of your talk recent developments such as artificial intelligence, big data, machine learning, predictive analytics, and you showed some recent examples related to hemodynamic monitoring. You might be aware that in the January issue of the intensive care medicine, there was a pro-con debate on the question, is research from databases reliable? So my question to you is this a current hype about this big data thing, this data fishing you might also call it, or will it be over in 2 or 3 years, or does it really bring us forward? What is your opinion about this?
That's a very good question, Thomas. I don't think it will be over in 2-3 years from now. I think we will continue to see more and more ideas, projects, studies about big data and predictive analytics. But clearly, I think we have to stay away from novelty blindness. It's not because it's new and hype that it is useful. So we need to carefully assess the potential clinical value with well-designed and independent clinical studies. And you mentioned databases, and you know very well that clinical databases often contain wrong information. So you may have the best predictive algorithm on the planet. If you feed it with wrong information, you will end up with wrong predictions. So this is, the classical concept of garbage in, garbage out. And clearly a major limitation to the development and adoption of some of these new solutions.
Then there's a question about the fluid status of the patient. You touched on this topic as well. And the question, so we are aware of telling if a patient is in need of fluid, but is there also a way to tell if the patient is in the overfilling phase and if he should be fluid restricted? Can you elaborate on this? How can we detect this toxic fluid phase if you want?
I think if you want to detect fluid overload, I mentioned a few techniques. You can detect B lines, for example, using echo. But otherwise, the methods which have been developed to predict fluid responsiveness, they don't tell you if your patient is fluid overloaded. They simply tell you where the heart is operating on the Frank Starling curve. So clearly, if your patient is fluid overloaded, very likely your PPV values will be very low. Very likely your patient will not experience a significant rise in stroke volume during a passive leg raising maneuver, will not experience a significant drop in stroke volume during a recruitment maneuver, but your patient may be just close to the plateau and not necessarily fluid overloaded.
Okay, thank you. The next question is about an ongoing topic, it's arrhythmias. So which technology to monitor the hemodynamics can be accurately used in the setting of arrhythmia?
Yeah, it's a good question because if you look at most technologies, if not all technologies we are even using today, I don't think there are validation studies done specifically in patients with AFib, for instance. The SWAN or transpulmonary thermodilation or echocardiography, does it work in patients with AFib? It should work if you know a bit about the principles of the measurements. There is no reason to believe it doesn't work. Very often the confusion is coming from technical limitations and physiological limitations. So AFib is clearly a limitation to interpreting PPV, SVD values. You cannot, there is no meaning anymore. All patients with AFib will have a very large pulse pressure variation. It has nothing to do with their volume status. But it doesn't mean that you will not be able to accurately measure stroke volume with a pulse control technique or with Doppler or with echo. With echo, as you know, I'm sure there are many people listening who have echo expertise. In patients with arrhythmia, you just need to ensure that if you measure cardiac output, you include enough heartbeats so that when you average all your VTIs, you get a fair idea of what is the mean cardiac output.
So the N in your news algorithm stands for non-invasiveness. I often hear people saying, oh, these non-invasive techniques, they have less accuracy and less precision than the more invasive one, so they are not very useful because if I want to measure cardiac output, I have to exactly know the exact value. How do you deal with these criticisms? This applies to all your smartphone applications and technologies.
Yeah, it's a good comment as well. I think non-invasive does not always mean less accurate. Pulse oximetry is a very good example. It is non-invasive and it's accurate most of the time, right? So as a result, it is now part of a standard of care. Echo is non-invasive as well, and echo is, as far as I know, this is a reference to assess cardiac function. In addition, I think non-invasive tools give us the opportunity to monitor patients who otherwise would not be monitored. Today, thanks to non-invasive techniques, as I said, we can envision to monitor patients on the wards and even from home. And finally, we also know that trends are sometimes more important than absolute values. So even if some non-invasive techniques are less accurate, they may be useful to track changes. I showed you one example. This is this bioimpedance necklace that has been designed to measure cardiac output. Actually, no, that has been approved to measure cardiac output, but it was not designed to measure cardiac output. It was designed to track changes in thoracic impedance. The idea is that if you wear such a necklace and you have congestive heart failure, as soon as you will start to develop pulmonary edema, your thoracic impedance will change. It will be detected by the necklace. So the necklace is not accurate to detect or to quantify lung water. The necklace is just there to detect a change in thoracic impedance that very likely in this context of congestive heart failure will mean that you are developing pulmonary edema. Actually, before you develop symptoms, there are studies showing you will be able to detect these subtle changes in thoracic impedance. Then you will be in a position to modify the therapy and possibly to prevent hospital admission. So, you know, this is the idea, this is the philosophy. You do not always mean a super accurate measurement. Sometimes the trends are actually variable as well.
Sometimes the trends are actually
variable as well. You also mentioned this concept of personalized or individualized hemodynamic monitoring and management. We more and more use these protocolized, goal-directed hemodynamic approaches currently. Is that, does it mean that this is not sufficient anymore? Should we individualize even the goals for every patient? And is this feasible in your opinion?
That's also a good one. I think protocols, to make it short, they have been very useful to rationalize what we do, to ensure we stay away from major deviations from bad habits, like giving fluid anytime the blood pressure drops. And that is the reason, I think, why studies have been able to show outcome improvement. But I think clearly today we can go further, and I tend to believe that the future is personalized management. You know, the first studies where personal goals are used are very positive. I mean, I shared with you the study from Futier, where they used your personal blood pressure as a target during surgery. And I mentioned the study from Bernstein, so my little finger told me the results are also pretty impressive. And the thing is that many clinicians are reluctant today to use protocol A or protocol B, and would tell you that most of the time what they do when they use a monitor is simply to maintain hemodynamic variables close to baseline value. So I think the personalized approach will be easier to understand and so easier to accept. So I expect a much easier adoption by anesthesiologists. The thing is that, of course, as I mentioned in my lecture, the baseline values before induction, before premedication, are often unknown. But as you understood, these may change in the future with tools enabling an easy and quick evaluation of blood pressure and cardiac output during the preoperative visit or simply on the wards the day before surgery.
All right, I think we are at the end of the webinar. We had almost 300 participants and we had a lot of intelligent questions. Thank you very much. Thank you, Frederick, for your excellent overview that you gave us about these technologies. And again, I would like to remind you that this presentation will be on the website of the ESICM shortly. And also that Dr. Frederick Michard offered to address questions personally to him. You still see his email address on the screen, so don't hesitate to directly consider him if your questions was not put forward here. And with that, again, I would like to thank Frederick for his excellent speech. I would like to thank I would like to thank the ESICM for organizing this, and I would like to thank all the listeners for listening, and I would like to wish you a nice evening, and hope to see you again at one of our webinars or master classes or at the next congresses. Thank you very much, and have a nice evening.
Thank you all. Thank you, Thomas. Bye.
Thank you very much and have a nice evening.